Next, we will look at diagnostic tests. Every diagnostic test you perform as a physician needs to be taken with a grain of salt. And these grains of salt, so to speak, are sensitivity, specificity, the positive predictive value, and the negative predictive value. Now, you'll be expected to be able to calculate and manipulate these numbers on step 1, so mastering them is actually important. We'll try to go through how you do that now. So first, let's review how to approach questions that deal with diagnostic tests. You should always start by drawing a 2x2 table comparing the test results with the actual presence of the disease as shown here. Now, just to run through this really quickly, a true positive is when the patient has the disease and the test is accurately able to recognize the presence of the disease. Whereas a false positive is when the patient does not have a disease, but the test comes back saying that the patient has that disease. Likewise, a false negative is when a patient has a disease, but the test is unable to pick it up, so it says the patient does not have a disease. And lastly, of course, a true negative is when the patient doesn't have a disease and the test accurately says that it doesn't have a disease. So looking at this table, we see that true positives and true negatives are when the test is accurate. It actually reflects the reality of the patient's health status. Whereas false positives and false negatives are when the tests are inaccurate. So what is the benefit of constructing this table? Well, it can be used to calculate sensitivity, specificity, and positive predictive value, negative predictive value. The sensitivity and specificity are parameters that describe the actual test itself, whereas PPV and NPV, or positive predictive and negative predictive value, describe how to interpret the test result in a clinical situation. So let's start with discussing sensitivity. This is the ability of a test, as we said, to detect a disease when it is actually present. The sensitivity of a diagnostic test is defined as the proportion of people with the disease who test positive, or the true positives, divided by the sum of the true positives and false negatives. So when is a highly sensitive test most useful? A test with high sensitivity is a great rule-out test. And so that's where we get this mnemonic, SNOUT, which lets you remember that sensitivity is good for ruling out. So why is this the case? If a test has a high sensitivity, or a sensitivity value that approaches 1, this equation shows you that the false negatives must be equal to 0. And therefore, all negative test results should actually be true negative. Hence, a negative test result in a highly sensitive test rules out the possibility of a disease. Now, a diagnostic test with a high sensitivity is useful for screening diseases with low prevalence. For example, an ELISA is a test with high sensitivity and is a good rule-out test for what disease? HIV. In contrast, specificity is the ability of a test to indicate non-disease when the disease is not present. Specificity is defined as the proportion of all people tested without a disease who test negative, or the true negatives, divided by the sum of the true negatives and false positives. What is a test with high specificity good for? Well, you can remember it by using the mnemonic SPIN, which tells you that specificity is good for ruling in a disease. And the logic for this is similar to what I just described. A specificity approaching 1 is desirable for ruling in disease and indicates a low false positive rate. If the specificity of a test is 1, this equation shows you that the false positives have to be approaching 0. Thus, all the positive test results would be true positives. Hence, a positive test result in a highly specific test confirms the presence of a disease. A diagnostic test with high specificity is useful as a confirmatory test after a positive screening test. For example, in a positive test result for HIV with ELISA, you should confirm it with what highly specific test? The answer here is the Western blot. So building on this concept, we arrive at the conclusion that the ideal test would probably have very high sensitivity and very high specificity. However, usually there's a trade-off between the two. And this graph shows you how you can shift the trade-off between sensitivity and specificity by adjusting the threshold for what you consider a positive test. So this curve in blue represents patients without the disease, whereas this line in red represents all of the patients with the disease. So let's go through an example to show you how this trade-off can occur. Let's say we want to use systolic blood pressure to detect cases of hypertension. So what do we normally consider to be a normal systolic blood pressure? So let's say ideally it's somewhere around 120. So you have a range of uncertainty, let's say from 120 to 160. Now, if I take a patient's blood pressure, depending on where I set my threshold, I can have a test with different sensitivity or different specificity. So let's go through that. If I set the threshold low at 120, then I will pick up all the cases with no false negatives. So this is a very sensitive test. Essentially, all of my patients with the disease, all the patients within this red curve, are picked up by my test. However, I will also have lots of false positives, and that's represented by all of these patients within the blue area that would be considered positive by my test. Using the same example, let's say I set my threshold at 160. Here I would exclude all patients without hypertension. If I draw my line here, I see that all of the patients under this blue curve are not detected by my test. However, I will also have lots of false negatives, and that is represented here by all of these patients within this red curve that would come up negative. What if I set some intermediate threshold here? So this is my 120, and this is my 160. Well, now this test has a balance between false positives, which would be all of these patients here under the blue curve, and false negatives, all these patients here under the red curve. One way the boards like to test this concept is by showing you an operator curve like this one. The y-axis will be sensitivity and the x-axis will be 1 minus specificity. Which curve on the graph represents the most sensitive and specific diagnostic test? That's right, the choice here is A. This test shows a sensitivity that rises quickly when specificity is close to 1. The test is able to distinguish well between disease and non-disease populations. This curve has no predictive value, and D and E are both distractors. We have more business still with this 2x2 table. The positive predictive value is defined as the proportion of positive test results that are true positives divided by the true positives plus the false positives. It is the probability that a person actually has a disease given a positive test result. When a patient asks what are the chances they have a disease after receiving a positive test result, this is basically what they're asking you for, the positive predictive value of that test. On the other side of the coin, the negative predictive value is defined as the proportion of negative test results that are true negatives, or true negatives divided by true negatives plus false negatives. When a patient asks what are the chances they don't have the disease after receiving a negative test result, this is what they're asking you about, negative predictive value. A critical point to remember is that both the positive and negative predictive values of a diagnostic test vary with the prevalence of a disease, while the sensitivity and specificity of a test do not. So, a high prevalence leads to a higher positive predictive value and a lower negative predictive value. Thus, even if the prevalence of a disease in a population is low, even tests with a high specificity will have a low positive predictive value. On the other hand, if the prevalence of a disease in a population is high, the negative predictive value goes down even if the sensitivity is high. Thus, the higher the prevalence, the higher the positive predictive value, and the lower the negative predictive value. The lower the prevalence, the higher the negative predictive value, and the lower the positive predictive value. If you're having a difficult time understanding this concept, remember that prevalence is defined as the number of people with the disease divided by the size of the population. You can put some example numbers into the test versus disease table to see how a change in disease prevalence affects positive predictive value and negative predictive value. I know that's a lot of information to digest, but let's do a practice boards type question to apply our new knowledge to something more concrete. A new assay for detecting prostate cancer is being tested in 120 patients without the disease. 108 of them received negative test results. What is the specificity of this new assay? So let's begin by looking at our 2x2 table. From the information, we know that 108 patients received a true negative result, whereas we also know that 12 got a false positive. And again, because 120 patients did not have the disease, and 108 of them got negative test results. So just plugging everything into our equation for specificity, which is true negatives over true negatives plus false positives, we end up with 108 over 120, which equals 0.9. Let's do one more question for fun. It is discovered that the zombie apocalypse currently invading the world is spread by a virus. The virus happily can be detected by an ELISA assay developed by the WHO. There is no vaccine yet. The outbreak started in China, and thus the virus has affected 10 times as many people in China as in the United States. How are sensitivity, specificity, the positive predictive value, and the negative predictive value affected by these facts? So let's think through this together. The sensitivity and specificity are not changed by disease prevalence because they are inherent to the test itself. However, the positive predictive value will increase as prevalence increases. So, it should be higher in China. And the negative predictive value will decrease with increased prevalence and thus should be lower in China. Think of it this way. If you live in China where more people are turning into zombies, it's 10 times more likely that you are a zombie. So even if the test is false, there's still a greater chance that the test is a false negative because you're 10 times as likely to be a zombie.